Robert is 71 and he feels the urge to go. So he sits down, and within a few seconds he knows something frustrating. The stool feels close. Not somewhere high up in his abdomen, right there. He pushes, a little happens, then nothing. He waits. He pushes harder. He waits some more. Eventually he gets up. And 10 minutes later, he still has that unmistakable feeling that he never actually finished. This has been happening more and more lately. So Robert reaches the conclusion almost anyone would reach. My bowels are getting slow. This is just what happens as you get older. But what if his colon isn't the part that's failing? Here's the reframe that changes this entire problem. And I'm giving it to you now rather than making you wait for it. Sometimes stool makes the entire trip through the colon perfectly well. It arrives. It reaches the rectum. The delivery was successful. The problem happens in the final few centimeters, at the exit itself. The stool got there. The exit didn't open properly. And that distinction matters enormously because it changes what actually helps. If you spend years treating a delivery problem, when you actually have an exit problem, you can do everything right and still feel exactly the same. So the real question is this: what has to happen for stool to leave normally? Because most of us have never thought about it. It's supposed to be automatic. And when something automatic stops working, we don't have a mental model for what broke. Let's build one. Most people picture the exit as a simple hole. Stool arrives, stool leaves, gravity and pushing do the rest. That's not what happens at all. Think of it as a delivery truck backing up to a garage. The colon's job is to move the truck toward the garage. That part is transit, the long journey. But arriving at the garage door is not the same as getting inside. The door still has to open. And it has to open at the same moment the truck is moving backward. If the truck pushes while the door stays shut, nothing gets delivered, no matter how hard the engine works. Here's what actually has to happen, in order. Stool enters the rectum. The rectum senses that it's filling, and sends a signal. That's the urge you feel. Then when you sit down and decide to go, several things need to happen together. Your abdominal muscles and diaphragm generate downward pressure. That's the push. At the same moment, the muscles of your pelvic floor need to relax and drop. And the anal sphincter, the muscle that's been holding everything closed correctly all day, needs to release. Now notice something strange about that list. Some muscles have to work harder. Other muscles have to do the opposite and let go. And they have to do it at the same time. That's the part almost nobody is ever taught. Defecation is not a strength contest. It's a coordination problem. It isn't about maximum force. It's about force in one place and relaxation in another simultaneously. Which means there's a whole category of failure that has nothing to do with how hard you push or how much fiber you ate. So why would someone feel stool sitting right at the exit and still be unable to empty? There are two very different answers. Let's start with the simpler one. The first possibility is that the exit mechanism is working fine, but the material trying to pass through it is the problem. Here's the basic physics of it. One of your colon's main jobs is absorbing water. As stool moves along, water gets pulled out of it and back into your body. That's normal and useful. But it has a consequence. The longer stool stays in the colon, the more water gets absorbed and the harder and drier it becomes. Hard, dry stool is simply more difficult to move through an outlet, even a perfectly functioning one. And this is where the honest version of the age question comes in. Constipation does become more common in older adults. That part is true. But constipation is not a normal, inevitable consequence of getting older. And I don't want anyone accepting it as one. What actually happens is that factors tend to accumulate with age. Medications, and there are quite a few common categories that can slow things down, including certain pain medications, some blood pressure drugs, iron supplements, and various others, reduced mobility, illness, eating and drinking less, neurological conditions, sometimes surgery or structural changes. That's a very different statement than your bowels wear out. And an important note on medications specifically: if you suspect one of yours might be contributing, that's a conversation with your doctor or pharmacist. Do not stop a prescribed medication on your own to test the theory. Now, when this progresses far enough, hardened stool can become retained in the rectum and stop passing altogether. That's called fecal impaction. And it's not just ordinary constipation with a worse mood. It's a medical situation that needs professional treatment. I'm not going to describe how to deal with it at home, because that's genuinely not something to attempt yourself. But here's where this gets interesting. And here's the part that opens up the real mystery of this video. Some people describe exactly the same feeling. The sense of being blocked right at the exit, and their stool isn't especially hard at all. It's reasonably formed, it's soft enough. By every measure, it should pass. And it still won't come out. That's the pattern that points towards something entirely different. If you find this kind of explanation useful, where we take a frustrating everyday problem and actually explain the mechanism behind it, subscribing helps more people find this channel. And I'd like to know in the comments, when this happens to you, does the stool tend to be hard and difficult from the start, or reasonably soft, but still impossible to pass? That difference is the entire subject of this video, and it's worth knowing which one describes you. Now let's talk about what's actually happening in that second group. There's a clinical term for it: dyssynergic defecation. I'll say it once and then translate it, because the term itself is more intimidating than the concept. Dys means faulty. Synergy means things working together. So, dyssynergia simply means the muscles involved in emptying aren't coordinating correctly. Remember what we said had to happen simultaneously. Push down while the pelvic floor and outlet relax and open. In dyssynergic defecation, that coordination breaks. The person pushes downward. That part works, but the pelvic floor or the anal outlet doesn't relax enough at the same moment. And in some people, it does something worse than not relaxing. It actually tightens. Go back to the garage. The truck is backing up, the engine is working. The driver is doing exactly what you'd expect, but somebody is accidentally pulling the garage door closed at the same time. More pushing does not solve that. It just means more force applied against a closed door. And this explains something that otherwise makes no sense. Why straining harder often produces so little, and why some people can strain for 20 minutes with almost nothing to show for it. They're not weak, they're not failing to try. The signal to push is being delivered perfectly. The problem is that the door is receiving the opposite instruction. Now, I need to be very careful here, and I want to be explicit about why. The symptoms we've been describing, the sensation of incomplete emptying, the feeling of blockage at the outlet, prolonged straining, needing unusual positions or maneuvers to get anything to happen, those symptoms can suggest an evacuation disorder. They cannot prove one. Symptoms alone do not diagnose dyssynergic defecation. That's not me being cautious for legal reasons, it's a genuine clinical fact, and it matters for a practical reason we'll get to shortly. Plenty of other things can produce a similar feeling. Hard stool, impaction, structural problems in the rectum or anal area, medication effects, neurological conditions, sometimes a combination. So the point of this section isn't for you to diagnose yourself. It's for you to know that this category of problem exists, because a great many people have never heard of it at all. But there's a question you're probably asking right now, and it deserves a straight answer. If this coordination worked automatically for 60 or 70 years, why would it stop? The honest answer is that researchers don't have one single explanation, and it likely differs between people. What's understood is that this is generally a learned or acquired pattern rather than something aging does to you on its own. I want to be clear about that, because it would be easy to hear this and conclude your pelvic floor is simply wearing out. That's not what the evidence describes. Several things may contribute. A period of painful bowel movements from a fissure, hemorrhoids, or hard stool can teach the body to tense that area during defecation, and the habit can outlast the original pain. Childbirth injury or pelvic surgery can change how those muscles function. Some people appear to have simply never developed a fully coordinated pattern, and in some cases it accompanies a neurological condition. Notice the useful implication in that list. If a pattern was learned, a pattern can potentially be relearned. That's precisely why the treatment we'll discuss shortly looks the way it does. And that leads to one of the strangest things about how constipation gets treated. What if you've been treating traffic on the highway, when the problem is the exit ramp? Let me be extremely clear about something before I go further, because this next part gets misread constantly. I'm not telling you fiber is bad. I'm not telling you laxatives don't work. They are genuinely useful tools, and for many people they're exactly the right ones. If stool is too hard, softening it helps. If transit through the colon is slow, moving things along helps. The point is narrower and more important than these don't work. The point is that different bottlenecks require different solutions. Picture a highway leading to an exit ramp, and the exit gate at the end is jammed. Adding more cars to the highway doesn't fix the gate. Speeding up traffic doesn't fix the gate. You could have the smoothest, fastest highway in the country and still have cars backed up, because the problem was never the highway. That's the situation for someone whose colon is delivering stool to the rectum just fine, but whose outlet isn't coordinating. Making more stool or moving it toward the exit faster doesn't retrain the exit. And this is exactly the pattern people describe when they finally get evaluated. I drink plenty of water. I eat fiber every day. I've tried 3 different laxatives, and I still feel blocked at the end. Now that pattern by itself does not prove pelvic floor dysfunction. I want to keep saying that, because it's the honest position. But it is one of the main reasons a clinician might stop escalating generic constipation advice and start asking a different question: is the evacuation mechanism itself working? There's a real number worth knowing here. Among patients investigated specifically for chronic constipation, some reviews have found dyssynergic defecation in as many as 40%. That's people already referred for investigation, not the general population, so don't apply it to everyone. But it tells you this is not a rare curiosity. Within the group of people whose constipation isn't responding to the usual advice, evacuation problems are a substantial share. And here's the part surprisingly few people are ever told. The outlet can actually be tested. This isn't guesswork. Let me walk you through what that evaluation typically involves in plain language, because I think knowing what to expect removes most of the dread. It starts with the least technical part, a careful history and a physical examination. A clinician asks detailed questions about the pattern, not just are you constipated, but what specifically happens when you try to go. The examination can give an experienced clinician meaningful information about how the pelvic floor and sphincter behave. Then there are a few tests that look at the mechanics directly. One is called a balloon expulsion test, and the concept is about as straightforward as it sounds. A small balloon is placed in the rectum and filled with a bit of water. Then you're asked to expel it privately, the way you'd have a normal bowel movement. If the mechanics are working normally, most people pass it fairly quickly. Difficulty expelling it suggests something in the evacuation mechanism isn't functioning as expected. It's a simple test, and it gives real information. Another is anorectal manometry. A thin, flexible catheter with pressure sensors is placed in the rectum. Those sensors measure what the pressures are actually doing in the rectum, in the anal sphincter, in the pelvic floor region, while you rest, while you squeeze, and critically, while you attempt to push as if having a bowel movement. And that last measurement is the revealing one, because it can show objectively whether the sphincter pressure drops the way it should during pushing or whether it rises instead. That's the garage door being pulled shut, captured on a graph. Sometimes imaging is used as well, defecography, which visualizes the process during a simulated bowel movement, usually when there are remaining questions about structure or function. One honest point about all of these: no single test is perfect, and clinicians generally interpret them together rather than relying on any one result. The tests inform a judgment. They don't replace it, but here's why I've spent time on this at all. If your problem is the exit, there is a way to find out. That's a very different situation from being told to eat more fiber for the 5th year in a row. And if the answer is that the coordination is the problem, there is a treatment for that specifically, which is what most people have never heard of. For confirmed dyssynergic defecation, the main evidence-based treatment is pelvic floor biofeedback, sometimes called anorectal retraining. The name sounds vaguely mystical. It isn't. It's one of the more concrete treatments in medicine. Here's the problem it solves. You cannot see your pelvic floor. You cannot easily feel what your anal sphincter is doing. When you push, you have no idea whether that muscle is relaxing or contracting. The feedback simply isn't available to you. That's the entire difficulty. You've possibly been doing the wrong thing for years, and there was no way to know. Biofeedback fixes the information problem. Sensors measure what those muscles are doing and display it on a screen as a line or a number you can actually watch in real time. Suddenly you can see it. You push, and you watch the line go the wrong direction. You try something different, and you watch it go the right way. Then, with a therapist guiding you, you practice. You practice generating useful abdominal pressure while simultaneously letting the outlet relax. Over repeated sessions, that coordination pattern can be retrained. Back to the garage one last time. Biofeedback is not making the door stronger, it's not making the truck's engine more powerful. It's teaching the door to open at the exact moment the truck moves backward. And this is where I need to correct a very common and genuinely counterproductive assumption. This is not do Kegels. Kegel exercises strengthen and tighten pelvic floor muscles. That's appropriate for some conditions, certain kinds of urinary incontinence, for example. But think about what we've just described. If the core problem is a failure to relax those muscles at the right moment, then training yourself to contract them harder is not obviously helpful. It may be exactly backwards. So please don't respond to this video by starting a large program of pelvic floor squeezing to fix constipation. That's not the same treatment, and it doesn't address the same mechanism. What does the evidence actually say about biofeedback? A systematic review and meta-analysis published in 2020 pulled together 11 randomized trials with a total of 725 participants with dyssynergic defecation. Across those studies, about 63% of patients treated with biofeedback reported clinical improvement, and the pooled analysis found biofeedback superior to non-biofeedback treatment. The authors were also candid that variation between trials and overall risk of bias were high, which is a real limitation and worth stating plainly. Longer-term data exists too. In one randomized trial following patients out to a year, those who received biofeedback maintained improvement in both symptoms and measured anorectal function, while standard therapy, diet, exercise, laxatives was largely ineffective in that specific group. And here's the detail I find most telling. The effectiveness of biofeedback appears to be specific to people who actually have dyssynergic defecation. It does not show the same benefit for slow transit constipation, which is the entire thesis of this video, demonstrated in the research itself. Match the treatment to the bottleneck, and it works. Apply it to the wrong bottleneck and it doesn't. Now, I'm not promising a cure. 63% improving means a meaningful number did not. This is an evidence-based treatment that helps many people, not a guarantee for everyone. But consider what that means emotionally for the person who's been living with this. Some people spend years believing their intestines are lazy, that their body is failing, that they're doing something wrong, that they just need to try harder, eat more fiber, drink more water, push more. And in some of those cases, the actual problem is a coordination pattern at the very last step, something that can potentially be retrained. That reframe alone is worth more than most of the advice on this topic. So what can you actually do with this information? The first and most useful thing is to pay attention to the pattern and be specific about it. Not "I'm constipated." That word covers several completely different problems and tells a clinician relatively little. Instead, is the stool consistently very hard and difficult to produce at all? Or is it reasonably formed, but it feels trapped at the very end? Do you regularly feel like you haven't finished? Even after going, are you straining for long periods? Do you need unusual positions or maneuvers to get anything to happen? And has this persisted despite ordinary measures? Those specifics point toward different bottlenecks, and they're what a clinician actually needs to hear. Second, and this one matters for your safety, try not to turn every bathroom trip into a pushing contest. Prolonged, forceful straining is not a treatment. It's uncomfortable, it's unproductive when the outlet isn't cooperating, and over time it can contribute to other problems in that area. If nothing is happening after a reasonable attempt, getting up and trying later is a more sensible response than escalating force. Third, support normal stool consistency with ordinary healthy habits appropriate to your own medical situation. Adequate fluids, reasonable dietary fiber, movement where you're able. I'm deliberately not giving numbers or a specific regimen because the right approach genuinely depends on your medical situation, your medications, and what's actually causing your problem. Someone with heart failure has different fluid considerations. Someone with a bowel condition has different fiber considerations, and dramatically increasing fiber is not automatically helpful. For some people with evacuation problems, it can make bloating and discomfort worse. Also, please don't start doing DIY enemas repeatedly at home. That's a route to irritation and other problems, and it doesn't address a coordination issue at all. And a brief word about the toilet footstool, since it's the single most common piece of advice on this topic. Putting your feet on a small stool changes your position, and some people find it more comfortable. If it helps you, use it, but I'm not going to sell it to you as the secret. A randomized trial in people with undifferentiated constipation found that using a footstool did change posture, but did not improve balloon expulsion time or the perceived ease of evacuation. So, harmless, possibly comfortable, not a treatment for outlet dysfunction. That's the honest position. Fourth, and this is the most practical thing in the entire video, If your pattern is specifically that stool seems to reach the end, but you cannot evacuate it properly, and especially if that's persisted despite ordinary measures, you now have language to bring to a clinician. You can ask, could this be an evacuation disorder or a pelvic floor coordination problem? And would anorectal testing or pelvic floor biofeedback make sense in my case? Those two questions can redirect an entire conversation. They move it from a generic constipation discussion toward the specific mechanism that might actually be involved. Before we finish, there's an important boundary I need to draw. A new or persistent change in bowel habits after 60 should not automatically be filed under normal aging. Not by you, and not by anyone else. Certain features specifically warrant medical evaluation rather than self-management. Rectal bleeding, or blood in the stool. Significant new abdominal pain or swelling, vomiting, unexplained weight loss. A major persistent change in your bowel pattern that's new for you. Or being unable to pass stool or gas while symptoms are getting worse. That last one needs prompt attention. Anemia found on blood work, or a family history of colorectal cancer, also change the picture and are worth raising. None of that is meant to alarm you. Most constipation is not caused by anything sinister. But most is not all. And the entire point of this video is not assuming you know which mechanism you're dealing with. And as I mentioned earlier, fecal impaction is a situation that needs professional treatment. Please don't try to manage it yourself. So let's come back to Robert. He started where nearly everyone starts. He believed the answer was to push harder and that his body was simply wearing out. What he understands now is that there were two completely different questions hiding inside his one problem. The first is, how did the stool get here? That's transit. The journey through the colon. The second is, can my body actually evacuate it once it arrives? That's the exit. Those are separate systems. They fail separately. And they need different solutions. If the stool is hard, you address the stool. If transit is slow, you address transit. But if the stool reaches the rectum and the outlet isn't coordinating, then pushing harder, or adding more fiber, or trying a fourth laxative, is applying effort to a system that was never the problem. So what's the fix? Nobody explains. It isn't one magic food. It isn't a special drink. It isn't a bathroom trick you saw in a 30-second video. It's finding the bottleneck. And when the bottleneck turns out to be coordination at the very last step, the answer may be retraining the exit, not forcing the gut harder. When something keeps getting stuck at the final step, don't automatically blame the entire journey.